a very brief opening statement and be available for questions. In medicine, there's no greater reward than to take a patient with a critically ill, serious medical illness and make them better, and we've done that. But to do this with a highly dangerous, highly contagious disease, to protect the staff and protect the patient and accomplish that is extremely rewarding, and UNMC is one of the few places where we can accomplish that. It took a team of about 60 people on the front lines and many people behind that to accomplish this, and I appreciate the support of the Chancellor and the Medical Center, the hospital, and innumerable people who pitched in behind the scenes.
So, questions for our panel?
You mentioned the safety factor for the staff. When the news broke out about people in Texas, healthcare workers in Texas coming down with Ebola, was there increased tension, or people that maybe were volunteering before not wanting to volunteer now to help with this patient?
When the situation in Texas occurred, I think our staff rose to the occasion and actually saw that the value they could do to improve things out there in the world were to educate others. And so instead of a time where they could have become more fearful, they were very confident in what they were doing and chose to use that as an opportunity to educate others. So they reached out within our own organization, they've reached out to across the community, and then we've also been able to, with our personal protective equipment guidelines and protocols, we've been able to share those really almost worldwide.
I would just add that there are facilities around the country that have had a great deal of difficulty getting enough people to volunteer to staff units that are standing up at the present time. Shelley has done a tremendous job of selecting and recruiting the best we have, and not only have we not had people, not only have we not had attrition, we've had people volunteering to work in these units, to work under these conditions, and in fact we have more people volunteering than we can really use.
How does the treatment of this patient differ from the last one as far as his symptoms or how he did throughout the course of it?
Well, we did receive this patient a little earlier than we received our previous patient, as you may know, and we do think that that actually significantly contributes to to this illness and our treatment of it. And the patient essentially received the same supportive care that we gave to our previous patient. He did, however, receive a different investigational drug than our previous patient received, which obviously he's done well, and we're very happy about that. But as we mentioned with our previous patient, we still don't know for sure if it's the supportive care, the investigational drug. He also received convalescent sera from Dr. Brantley as well, and so we're not sure exactly what made him better. We're happy he's better. But there were some differences in the care that he received, but all in all, the supportive care was essentially the same.
How many different blood transfusions did he get from Dr. Brantley?
We got a single transfusion from Dr. Brantley. It was a somewhat larger volume than a typical transfusion.
Will anyone else, any of these patients who have now overcome the virus, be able to give blood other than Dr. Brantley?
According to the CDC, we should wait a month before doing so, but after they recovered, Dr. Brantley had contributed blood and has done so on a number of occasions. Both of our patients have stated their willingness to donate blood after they recover, so I think they are grateful and they're willing to help out.
You had mentioned in one of the previous press conferences that the CDC will take a look at patients like Dr. Sakra and be able to possibly determine what it was that cured these patients. You know, what are the three things they were given? Do you have any information from that case yet?
The latest information I have is that we don't have enough information yet. The 15 or so patients that have been treated in the developed world have all been treated with different regimens, and the numbers are too small to really draw any definite conclusions. But the CDC is, I know, at this very moment, scrutinizing the changes in total amount of virus in the blood, comparing that to the timing of the different medications that they're receiving, and trying to figure out what drug to recommend. They're also looking at safety profiles and side effects that we might have recorded. So everyone is turning their information in, but there isn't enough. There's also discussion of trying to do controlled trials, perhaps in Africa, but this is in a very preliminary stage.
How is it decided which patient goes to which hospital in the States to get treated?
This is decided by the State Department, basically. Both of our patients were triaged by the State Department, and they called us and asked us if we're willing to take them. I know there's also input from the CDC, particularly in domestic cases.
How did the information that you gathered from the first patient help with the treatment as far as, for example, moving the lab into the biocommunity?
Yeah, I think that actually our treatment of the first patient gave us quite a bit of insight into the management of this illness. As you know, there have been very few numbers of people actually treated in the developed countries. And so, you know, with our first patient, we were all learning, and we're still learning. But I think that we were able to observe our first patient's course, his hospital course, the symptoms, kind of what goes on, his laboratory parameters, which was something that was really entirely new before the patients. The first initial patients arrived at Emory. And so I think that, you know, in consultation with other healthcare facilities that cared for these patients, we've really come to realize the course of this and what we need to do to manage these patients. And I think that, you know, the way that we learn is to continue to treat the patients and continue to monitor their parameters, and that's what we've done this time around. So I would say that our second patient, we did have a little more experience, obviously, in management of these patients and how best to do that.
Did having a lab in the unit help?
Yeah, so we moved the lab into the side of the unit, and actually that was, I think, a vast improvement just in the timing. These patients are sick people, and we want to make sure that we are able to obtain labs in a timely fashion, in a quick fashion. And then also just having our laboratory staff be inside the unit with us contributes, I think, to the overall safety of how those labs are managed. So yes, adding the lab in the unit, I think, was a definite improvement that we performed this time around.
Dr. Saker was admitted back into the hospital shortly after he became ill again. Any worries about Mr. Mukpo?
I think this infection leaves you in a weakened condition, and there's not been any instance that I'm aware of where someone has relapsed and the virus has come back. Dr. Saker had a standard community-acquired pneumonia. Fortunately, was treated well and is home now, and we've counseled our current patient that needs to be aware that he'll be weak. He won't be able to fight off infections normally. He won't have normal strength, and so as possible, he would be admitted to the hospital. When we send him home, we contact infectious disease experts in that community and hook them up with our patients so they have somebody to turn to if new symptoms develop.
Shelley, I'm wondering if there was no attrition, you had more people that were volunteering. Did it surprise you that a bit that there was a little backlash in terms of the private lives when the nurses and people were going home, such as that Earth Day on the bike?
It did surprise me a little bit, but again, it goes back to education, I think. This is new. This is something that, you know, everywhere you read, there's information out there. So I think it was not surprising, but I think as a team, we were able to really talk through some of the things, and we were able to give them some additional tools and resources to kind of use with their community and their families who had questions. So I was not at all surprised by the no attrition. This is a pretty remarkable and courageous team, and we're very close. And I think as things occur in their lives, we're sharing those and talking about those openly and really kind of processing through them as a team. But again, it goes back to education, I think.
And Shelley, I'm guessing that if there are stressful moments for you and your team, is there any sort of counseling or resources for people that you're working with if they feel like that?
Sure. Anytime that you have a situation where there's a lot of stress involved, we actually reach out as healthcare providers to individuals who have a background in behavioral health. So we do have someone who actually interacts quite often with our team members and spends time with us. So that's a resource. And then if we needed assistance through our hospital, we're able to also offer employee assistance of any kind.
Doctors, can you speak at all to Mr. Mukpo's condition? When Rick Saker left, he had, said that he still felt very weak in terms of this patient's physical condition. How is he doing?
I think it's fair to say he's very similar to these two, and they're very similar to other patients that we've talked to Emory and European hospitals about, that they tend to be weak and have a prolonged weakness beyond anything we even see with illnesses we associate with that, such as mononucleosis or influenza.
For the first patient you had, you said that you were a little surprised by how much medical waste there was. Was it similar in this case? And then walk us through what happens to that, because I know there's a bit of public concern, especially around the country, of like where it ultimately ends up.
Sure. Well, we have the unique opportunity here of having practiced and planned for this for 9 years. So unlike many hospitals, we have the autoclave that we use. So all of our medical waste actually is autoclaved, so completely decontaminated before it actually comes out of the unit. So, and then it's just basically sent to our distributor who takes care of our trash and waste for the rest of the organization. So it's completely autoclaved and everything that comes out is completely decontaminated. So it's a very unique situation.
So then does it just go to landfill after that?
It goes to incineration. Mhm.
Was there more medical waste this time? Does this patient pose anything different?
This patient posed no difference in medical waste. The only thing I would say is we brought our lab peers into our unit, so that did increase a little bit our waste from a personal protective equipment standpoint. But it was certainly comparable to what we were experiencing on the campus to begin with. So.
And you said that the standards developed here become standards for the world, but what's next for all of your staff in terms of training other facilities, other places, whether they be here or around the world?
Well, we're looking at a number of options, ranging from developing videotapes, developing curricula, having courses on site where teams of people could come in and tour our unit and see how we do things. I know that as individuals, we have all had hundreds of requests and hundreds of phone calls and various specific questions about advice and isolation, medical care, and so forth. And so I think with this patient gone and before we get another patient, I think we're going to use that time to try to share our knowledge as best we can with the rest of the world.
Might be a good time for me to add that both Secretary Burwell and Secretary Hagel have reached out to us to congratulate and to thank our team for the wonderful care that they give, but also at the same time have asked for our assistance in suggesting programs and participating in educational programs and in clinical and basic research in an attempt to stop the spread of this both in Africa and to provide resources here in the United States. We are actively participating with both departments.
Every medicine you're trying right now is an experimental medicine. Any difference in the ones you tried this time versus the medicine that was tried with the initial patient at Emory? Have you noticed, are they both about the same effectiveness, or can you even tell?
We can't really tell that, only because our patients, as I mentioned, also received the convalescent sera as well as the supportive care. I will say that the difference in medicines this time is that our medicine here this time around is actually a pill as opposed to an IV infusion, which was what it was with the previous patient, which I think is promising just in the delivery, overall delivery of medicines. You know, it's much easier to give a pill to someone than it is to administer an IV infusion. And so that's encouraging. I would say that we're very happy with the outcome, and both of these patients, obviously, they did receive different products, but overall, I think things have been very promising for our patients.
Is there a certain time frame you need to wait before you could accept another patient?
No, we could theoretically, if we go through all the approval process, we could accept one anytime. We could accept one this afternoon. We have an internal approval process and also coordinate with the Nebraska Department of Health. We're going through a cleanup now, which takes a number of days, but that can be interrupted if somebody with Ebola needs to be transferred.
What is involved with the cleanup now that the patient's gone?
So for example, today we're just spending the rest of the day autoclaving everything out, all the linens, all the trash, and getting those taken care of. And then our next step would be to let the unit sit for a couple of days and the virus allow that to desecrate on its own a little bit. And then we'll come in and do a thorough cleaning on the weekend. And then we'll use maybe some other tools such as UVGI, ultraviolet, to just add and enhance that cleaning process. So it's cleaned at least a couple of times and lots of different steps involved. But as Dr. Smith said, if we're needed, then that obviously can be expedited.
We are lucky enough to have a decontamination team, actually, that is part of our leadership group. We have 2 individuals from the College of Public Health who are highly trained in decon, and that's essentially what they do. And so we're very lucky here to actually have that expertise here on campus. And so they essentially are in charge of every aspect of our decontamination process. And that's another thing that we have been sharing, actually, with other people, not only in the United States, but around the world. Because that's another question that people always have is how, once the patients leave, what do you do with the facility? So again, we're very lucky to have that expertise here on campus.
Can you accept only one patient at a time?
No, we're a 2-bed unit. We've only had 1 patient at a time, but we feel we have the staff to comfortably accept a second patient if that's necessary.
You mentioned the 2 beds, but yet you have 10 beds in the facility. Is that because of the unique equipment necessary for Ebola treatment? In other words, why have the 10 beds if you can only take care of 2?
Yes, 2 reasons for that. Number one is, as you alluded to, Ebola. Patients are very sick. There are a lot of bile secretions that are highly infectious, and you need a lot of equipment in the room. So there really is only 1 patient that can be comfortably taken care of in a room with Ebola. With some other diseases, it might be different. The other thing is we have made improvements in the last 10 years, and one of them was turning 1 room into a laboratory. We turned another room into a dirty utility room, and a 3rd one into a clean utility room. So these are needs that were not necessarily anticipated 10 years ago when we were thinking about smallpox and SARS, but that has resulted in a decrease in the functional number of rooms that we have.
The other rate limiting step for us is that because we autoclave all of our trash and linen out, it takes a lot of time to do autoclaving.
How long does it take to autoclave 1 load?
1 load is about 30 minutes.
So would you say, it's fair to say that the autoclave would run half the time when there's 1 person in there? If there were 2, it would run full time?
Much 24/7.
We didn't hear a lot about what Mr. Mukpo was doing these last few days. Is he going to be able to exercise or do whatever what else he had to do in the unit?
Yeah, we did a physical therapy consult very early on, and he had an exercise bike in the room and used TheraBands and kind of had his own exercise regime that he was doing. So he was very active during those last few days here.
When were those tests, the blood tests that came back negative from the CDC, when were those samples taken? When did they come back?
Well, I can't be specific because of some of the patient privacy issues, but I can say that it takes several days for the samples to go to the CDC and be run, and all the samples were negative. So it's not just today, but a number of days in the past that this has been the case.
Any personal anecdotes? I know you were amazed with Dr. Sakra, how he was able just to see pretty much your eyeballs, but he was able to figure out who you were by your voice and such as that. How about the Ashoka?
This morning our team had the opportunity to have kind of a warm reception with him as he came out of the unit, so that was very heartwarming, and he had very kind things to say about the team, and actually, identified a few individuals who really made a difference for him, and just really talked about his appreciation for the entire team. So that was very special to us to have that time with he and his family this morning.
And I would add, as with Dr. Sakra, once he got through the critical part of his illness and was able to talk, he had a number of anecdotes about what it was like to be hospitalized in a facility in Liberia where you didn't have IVs, where it was extremely hot, where there was very little medical care, and a number of observations on the impact of this terrible epidemic in Africa. And so we've learned from our patients as well as helping them medically.
Is there anything you can point to how he got out, I guess, almost, 5 days sooner than Dr. Sakra?
I'd say a lot of it has to do with his age. He's about 20 years younger, and it might also have had to do with the amount of virus he had in his system. But I think age is the main factor.
Can we just see if there's anybody on the phone?
Hello, can you hear me?
We can hear you, yes. Please identify yourself and ask a question.
Yeah, this is Lenny Bernstein at the Washington Post. This isn't a question, but before I start, no one has identified themselves, so we have very difficult time telling who has been speaking over the past 30 minutes.
So we'll do that for you. This is Jeff Gold. I'm the Chancellor of the University Medical Center, and
Yeah, I'm Dr. Angela Hewlett, Associate Medical Director of the Nebraska Biocontainment Unit.
Yeah, I'm Phil Smith.
Spell that last name?
Hewlett,
Spell that last name?
Hewlett.
Mm-hmm.
And I'm Dr. Phil Smith, Medical Director of the Biocontainment Unit.
Yours is easy.
Sometimes the audio was going in and out, so I apologize if I'm repeating the question here, but what is your capacity there in terms of both beds and staff? How many people can you handle, at maximum capacity, both in terms of beds and staff?
In terms of beds and what? Staffing. Our maximum capacity for patients at this point is 2, and we picked that number for a variety of reasons we talked about earlier, and that's designed to maximize patient safety. Want to comment on the nursing?
We have adequate nursing staff now to be able to care for 2 patients at a time. It does take several staff per shift because we have very strict roles and responsibilities. You have the caregiver in the room. You have a caregiver in the hallway who does nothing but watch individuals who come out of the room, take off their personal protective equipment, and follow every protocol and procedure to the T. It requires somebody to do the autoclaving. It requires somebody to help individuals put on their personal protective equipment. And then we also have someone who needs to be at the desk to answer the phone and look at the biologicals on the clean side of the autoclave and a few other tasks that need to be done. So it's pretty labor intensive given the structures in the process and the safety procedures for this type of virus. Oh, this is Shelley, and last name is Sweethelm, SCHWEDHELM, and I'm the nursing director for the Biocontainment Unit.
is there another question on the phone?
Each human being would get how many people assigned? Each patient would have how many people assigned?
We have 5 staff that would work every 12-hour shift, 5 to 6. It just kind of depends on where we're at with our autoclaving.
That's just nurses.
It's nursing, techs, and respiratory therapists is the complement of our team.
Plus physicians, pharmacists,
Right.
research team, security team, on and on.
Really hard.
Well, there are 5 to 6 nurses and techs and respiratory therapists per shift, and there are 2 shifts. Then, as far as physicians are concerned, I do want to tip my hat to the critical care medicine, pulmonary, and anesthesia, who have served now as primary care physicians and make most of the minute-to-minute clinical decisions on these patients. Every one of them also has an infectious disease physician, usually Dr. Hewlett or myself, or Dr. Kildall or Dr. Florescu, who is always on the case as well. Other consultants may be brought in as necessary.
And then we have our lab team, who there are 2 of those on as well per shift.
So a lot of people.
A lot of people.
So, yeah, in the unit, at any one time, you probably have 10 people, especially early in the morning when there's a lot of activity.
Thank you.
Is there another question on the phone?
Yes, this is Deborah Goldsmith from CNN. I have 2 questions. One is regarding the PPE of the staff caring for the patients. Now with the CDC having issued revised guidelines the other day, are you all following these revised guidelines or exceeding them, as it sounds like you had been doing previously? And my second question is regarding the investigational drug. Dr. Hewlett, you said that it was taken, it was not delivered in an IV like it was with Dr. Sakra, but it was given in a pill form. And so I would think that speaks to the state of his illness. If he was able to take medication by ingest rather than IV. Can you talk about that, please?
This is Shelley Sweethelm, and I'll answer the personal protective equipment question. We did have the CDC reach out to us, and we provided them feedback, and actually they were very gracious in acknowledging our support and input as they did push the new guidelines out to the CDC website. We are very close as far as comparability of what we're doing compared to what the CDC's new guidelines are, with the exception of they're suggesting 2 pair of gloves and we actually use 3. So I think there's very few other minimal differences. So we were very pleased and think that standard really supports the safety of healthcare staff across the country.
I think regarding your questions, Dr. Hewlett, regarding the question with the oral medication that was administered, I think that the key here is to make sure that we actually receive these patients early. If we can get them early in the course of their illness where they actually can tolerate an oral drug, then I think that obviously has lots of benefits. Number one, they can take the drug. Number two, we can intervene early and hopefully get some of these electrolyte disturbances and some of this dehydration and that sort of thing, and we can really kind of get a hold on that before things get bad. And so I think that the fact that this drug is a pill, again, is very encouraging, and that it could be, probably widely distributed more so than an IV formulation. And but again, you have to have the patient be able to tolerate oral medicines, and that is an issue.
Any other questions on the phone?
You are not revealing what drug that was?
Yes, no, we've revealed the drug. It's called brimcidofovir. It's an antiviral medicine. Mm-hmm.
Thank you. Questions from our audience here?
Are there going to be any type of restrictions that this patient's going to have to be under in terms of protecting his immune system once he's at home?
Oh, we let the CDC, this Dr. Smith, we let the CDC really help us decide. In fact, we let them decide when the patient's ready to go. They set up the rule of having 2 negative viral PCRs at least 24 hours apart, and they instruct us in the activity restrictions and any personal hygiene restrictions that there might be that this patient will follow. And beyond that, we counsel them with the normal limitations, especially for young people. We tell them not to be frustrated if they're weak, and they're probably going to be that way for several months before they get their full strength back. And they may be more vulnerable to other minor respiratory infections that would be coming along, especially this time of year.
But any type of restrictions in terms of, don't go outside, get an extra flu shot, anything like that?
No, there's nothing. The common sense things we will be telling people about the flu season. And you did a good job there. Get the flu shot. Wash your hands. If you're sick, stay home. The usual common sense infectious disease maxims still apply to this patient.
What about staff? What kind of restrictions are on your staff?
With our staff, we don't really have restrictions. We monitor them very carefully. When they're working, they have temperature taken twice a day, and they fill out a symptom checklist. And then even after the patient leaves and they return to their ordinary jobs, we monitor them for 21 days.
Can you give any details on where Mr. Mukpo is right now and the reason why it's out?
Oh, I do not have that information.
I just left him with his family before I came over here, and let's just say they were really, really pleased to be with each other.
Does he plan to return home to Rhode Island?
I believe that's their plan. That's where he's from.
The cost of this treatment is very expensive. Was he insured? Is NBC picking up the tab, or is this taxpayers picking up the tab? You know?
I am not for sure about that. I know there's a lot of discussion and problem solving going on around that right now, so I feel very confident that that's covered.
I think that's fair. Yeah, absolutely.
But I will add, to my knowledge, this is not a taxpayer-funded situation.
Anything else? Hearing not, I thank you very much for your time. I cannot tell you how proud we are to be able to participate in the care of Mr. Mukpo and other patients, and equally proud to be a national leader in developing educational programs and to continue our research to prevent and to treat these diseases.